Hello, and welcome to our webinar, Connecting the Bedside to the Webside, Virtual Nursing as a Service. And this is a co-presentation between AvaSure and Equum Medical. And we had over 200 people register for this webinar, so it's a topic of interest. So your lines will be muted. However, please type questions into the question box so we can address them during the webinar and there's a Q&A at the end as well. So I'm Lizbeth Votruba and I'm the Chief Clinical Officer for AvaSure. And I'm introducing my friend and colleague, Ashley Bonita, from the Chief Nursing Officer from Equum Medical. And I've really enjoyed getting to know you, Ashley, and I think we look at nursing practice and the way technology can support nursing practice in very similar ways. And I think your background is just perfectly made for the role you're in now. And obviously you're a lifelong learner, so please tell us a little bit about yourself.
Well, thank you. Thanks for having me. My name is Ashley. I have a doctorate in nursing practice. I have an MBA and an MSN, so very engaged in learning and nursing. I'm passionate about it, from starting out at the bedside over 25 years ago to being a CNO, and now my role as the Chief Nursing Officer at Equum. I know that nursing is essential for healthcare and patient outcomes. So today, I hope we get to discuss not the shortage, but the opportunities and how we can help alleviate the crisis that we're facing in nursing.
Thank you. We had some great questions even on the registration. And so this is just kind of the agenda of how we're going to go through the day. And some of the questions were about where do you start, and this is one of my favorite questions, does implementing virtual nursing actually impact hospital hands-on care? That's the real question here. So these two top bullet points that we're going to go through are definitely need to go together as a group. Like what are the challenges, what are the problems, and then what's the solution, and making sure they line up, that the solution is actually solving something on the challenge side. So we're going to talk through that. Some of the questions were more on, what is virtual nursing, or what are the models, what are other people doing? So spend a little bit of time defining virtual care models, and then from the AvaSure side, talking about how our technology supports virtual care and what technology pieces fit the best for different models, and some of the early outcomes we're seeing from some of our customers here at AvaSure. But then I get a lot of questions when I'm talking to leaders. Yes, we really want to get started with virtual nursing because there's a shortage of nursing. So how do I even find a nurse to hire to be the virtual nurse? And so that's why we wanted to bring in our partners, Equum Medical, who can help you with that question and provide expert virtual nursing. And we have a great partnership with them and have partnered on telesitter implementations and are really ready to partner on some virtual nursing as well. So Equum Medical, they are the people and process behind virtual care. And that's what Ashley's going to talk about as well today. So moving on to the next slide. I am a third generation nurse, and I've been in healthcare for 35 years, and never has there been a bigger need to do things differently, to look at our care delivery models, to think of new care delivery models, and understand where technology fits and where technology can enhance and elevate nursing care and help everyone practice at the top of their license. And I know from the list of attendees, I don't think anybody is unaware of stats. The problem on a slide like this is to figure out which worst stats to put on, but we know that there is a challenge in the shortage of nurses, as well as the experience complexity gap. So patients are more complex, patients have more behavioral issues, and the experience of nurses is lower as the more experienced nurses are retiring and leaving the profession, and novice nurses didn't get the same educational experience as we've come to expect from nursing school during the pandemic. And so there's that imbalance to address, and just a kind of a perfect storm, and that leads to pressures on hospitals, of course. I hear about care units that block off a certain number of beds because they don't have enough staff to cover all the beds on that care unit. And that impacts directly revenue, obviously, and we are not winning the quality battle right now as well. And so all of that puts together, and those are just some of the issues. You all have your own that are the most important. If it's flow, if it is, you have, like, I'll tell you about this care unit on the night shift. The most experienced nurse has been a nurse for 13 months. We hear that as well. So that is just an overview of some of the issues why virtual nursing is becoming such an important tool in the toolkit. And then on to the next slide, we're going to talk about some nurse elevated care models that leverage technology today. And earlier this year, AvaSure conducted market research about virtual nursing and other things too. It was not just like, oh, this is a survey about virtual nursing. It was a general market research survey, and we asked some questions about it. And 89% of the respondents, nursing leaders and hospital leaders, 89 were moderately or extremely interested in virtual nursing. None of them had fully implemented virtual nursing. So most were on that path somewhere, from conceptualizing it, doing a small pilot on one of their hospitals, or just on the early phases. And then in April, I attended a great session at AONL on virtual nursing, and they did an audience poll. And 80% of the audience was interested in virtual nursing, but only 2% had really implemented it. So I'm going to stop and do a poll now for you all who are on the line to give us, I want to see if those that market research matches up where we're at in November of 2022. So where are you on your virtual nurse journey? I made the assumption that you're interested or moderately or extremely interested in virtual nursing because you're taking the time out to be here today. So are you conceptually, are you just kind of planning, maybe you have been given this strategy to look into virtual nursing in the coming 6 months, and maybe you have a committee together and are on that discovery, or are you starting some kind of small, medium pilot that's underway, or have you implemented virtual nursing? So numbers are still moving. Okay, I'm going to give it a chance for me to sip my coffee, and then we'll see where we're at. All right, Laura, do you want to close out that poll? Okay, so if you feel like, oh, I'm not doing it yet, you're not alone. So 66% are just on that planning phase, 20 have started piloting, and 13 have implemented virtual nursing, 13%. So that makes sense. I think some of those that were conceptualizing in April have moved to the piloting stage. So great. Let's talk through some of the common models of kind of what we're calling nurse elevated care models, leveraging technology, and what the kind of the use cases can be. So the first one is a clinical resource telenurse option, and that is where one virtual nurse is doing one-to-one episodic care, and this is all of this is acute care and patient focused. And they really help support maybe admission and discharge documentation. We know that nurses spend about 25% at least of their time documenting. So being able to unburden some of that, as well as doing it really well and thoroughly and consistently. Being a nurse that can do 2-nurse sign-off for blood or chemo or high-risk medications. Patient education is huge, and when we get to some of the early outcomes that we're seeing, patient education can make a big impact. Maybe a specialty nurse, a woundostomy nurse, or and even other specialists accessing patients remotely on the inpatient side, and nurse mentoring. And I would say nurse mentoring needs to be woven in through all of them. And I see Ashley, we've been talking about this, that the mentoring piece is always part of it, no matter what model you're providing. So that's one-to-one. It's often focused in the med-surg or ED holding area. And then the expert oversight nurse is overseeing through the entire shift, not for an episode of care, a cohort of patients, often high acuity or isolation patients. And then they are, often in a sort of a hub, and they have physiologic monitoring, they have other inputs. Of course, any kind of virtual nurse is going to have the electronic health record, and that will be the source of truth. But that expert oversight might be having, quite a bit of information feeding, and the video visualizing the patient is a very important piece of the puzzle. So they're reviewing and responding to clinical triggers, and or bedside staff can call, kind of like a rapid response. And again, expert nurse supporting novice nursing, there's that mentoring piece, and supporting satellite facilities as well. So and within a health system, being able to support higher acuity patients who might be in a rural setting or a smaller setting, and help that setting retain the patient, which is great for the health system, and it's great for the patient and their families as well. And then the third case, I think most would be familiar with elevated care model, is the telesitter solution model. And that is where not a nurse, but a nursing assistant or a safety ambassador is monitoring multiple patients continually, keeping them safe, preventing falls, preventing elopement, and decreasing the need for one-to-one sitters. So you have one virtual staff member, highly trained, engaging with 12 to 16 patients continuously, instead of having 12 to 16 one-to-one sitters sitting at the bedside watching patients sleep. So I'm going to take another poll here, and wanting to wonder where you're at with this. If you had to choose a place to start, or your next on your journey, which would it be? That clinical resource nurse that's focused on med-surg, is doing admissions and discharges and documentation and mentoring. The expert oversight nurse might be more like a virtual ICU setting. They're monitoring a cohort of patients throughout their shift. Specialty nurse, we have, awesome woundostomy nurse or specialty nurse, but not all of our hospitals have access to their level of expertise, and we want to grant patients access to that level of nursing care remotely. Or are you at the point where we're getting started with the telesitter solution for patient safety and might build on it from there? And I'll give that just a minute. 57% of the audience has voted, so some people are answering emails right now. Maybe on their phone. Okay, where are we at with that, Laura? Okay, and this is kind of my gut, and I don't know, Ashley, if you too are kind of getting that impression that when you're, Ashley, what have you been seeing when you've been interacting about virtual nursing?
Very much the clinical resource nurse is highly sought after right now.
Yes. And I think I was talking to a nurse leader on Monday, And she said she's been in this, and she has virtual ICU set up and a telesitting program as well. But she really says the need is in med surg. That's where the novice nurses are, and that's where the ratios are getting, squeezed. And so that makes sense to me. All right, and then I just want to kind of match those up with what technology is recommended to go on with which type of use case. So next slide, Laura. So, and this is kind of a suggestion, and somebody wrote in a question, where to get started, or where would you recommend a hospital get started with virtual nursing? And that really is kind of a mutual assessment of where your needs are, but also kind of that impact effort mapping. What is maybe not the highest amount of effort or resource to get started, but also would have a high impact. So on the clinical resource nurse, there are a couple form factors for what would be in the patient room to interact with the patient. So one would be the mobile two-way device. So the patient, the virtual nurse can see the patient can see the nurse. And it's two-way audio, and it's a mobile wireless device that can be brought to that patient for their patient education, for their discharge. It can be brought into the room while the room is getting set up with the toothbrush and the and the emesis basin or the whatever on admission. And then the other form factor that could go in the room would be our Guardian Access device, which is visualized below there, which is a smaller device, maybe about this big, and it goes alongside the entertainment monitor in the room and can leverage that to also provide the two-way video. So the patient will be able to see the nurse on the screen there. And then the application that the nurse would use is AvaSure Connect, which is one-to-one. And so they see the one patient at a time, and then they're themselves, and they can move that around, dock it right over under the camera while their webcam, while they're documenting in the electronic health record. And that audio is always open. So it's hands-free, the audio is on, the two-way audio is on. And then on the expert oversight side, the hardware or the form factor that might go in the patient room, again, might be that Guardian Access mounted on the wall. It's priced to be in an every room solution, or Ceiling, which has the optical zoom for higher acuity. It drops right into a ceiling tile for higher acuity, high resolution, bird's eye view of the room. That's great for ICUs as well as emergency departments that have really, fast turnover. And the application that can be used for that is Verify, and you're looking at 38 thumbnails, a whole cohort of patients, and being able to round through, click through. Maybe, I've seen this at UC Health in Colorado, where they have, this is one of their outlying hospitals that they're monitoring in the top left, and another hospital here, and another hospital here, another one here, and this lower right-hand corner are the rapid response patients I'm keeping track of for the next 6 hours. So that's called Verify. And then on the telesitter solution side, any of the form factors can be used, and then the monitoring staff member is using our telesitter software application, which is 16 all at once. They're a lifeguard watching the pool. They've got to be able to see them all and interact with them. So that's just a quick overview. We're happy to go in more detail. And then we had lots of questions about what are the KPIs that you should track, or what are the outcomes. And as I talked about in earlier slides, a lot are on the implementation right now. There's not been as much published in the literature about virtual nursing as there has been about the telesitter solution. That we have almost 2 months. It's hard to even read all the evidence on the telesitter solution. So that's very evidence-based, and that's kind of a standard of care now. But virtual nursing has less, but there are some great outcomes coming. So on the clinical resource side, I did a presentation with Unity Point on at our symposium, and they are doing the clinical resource nurse, and they saw a 12-minute reduction on admission and 15 to 29-minute reduction of time, and that is time pulled away from the bedside nurse so that the virtual nurse can take on that time. So that's a gift. Here's a gift. I think nurse would rather have that than a pizza party. I would like some time back, and so this is time that's given back to the bedside nurses by the virtual nurse on admission and discharge. And with that high level, and remember, this person is a mentor, and I hope, Ashley, you talk about how you hire mentors and experts, because that is such a piece of it. But it's a highly effective admission and discharge, and they're doing great education, more and really effective with it. And so they also talked about 107 catches, great catches that they had at discharge that might have resulted in patient harm. And I'll just give a few examples. One was a patient being discharged to a skilled nursing facility with the wrong code status. There was a patient who was being discharged with diabetes, but they had kind of slipped through the cracks. They hadn't been educated on how to self-administer insulin, or a CHF patient that needed some teaching before going home. And some of the other good catches were more on the mentoring side. And she talked about a patient who was, I can't remember what their diagnosis was, but the virtual nurse was helping out, and they said to the novice nurse, that patient's going to throw up pretty soon, and there's no suction in the room. And so go get the suction. You need to get suction set up. And they did, and sure enough, the patient did start vomiting soon after that. And the novice nurse was like, how did you know that was going to happen? And being able to see in there, notice what's missing, and have that kind of support, and that, maybe preventing an aspiration pneumonia right there. And then, and also I'm going to skip down to the patient experience. And she talked about that something that surprised them was that patients said, the virtual nurse was the only nurse I interacted with during my whole stay that wasn't wearing a mask. And I was able to, communicate better. And I'm hard of hearing, and I didn't realize I really kind of depend on being able to see someone's face while I'm talking to them. And so the education was more effective in that way also. So they saw increases on their HCAHPS, both on the understanding of new medications and about the whole transition of care discharge process. And that is what leads to, and the great catch is what leads to decreased readmission rates. So she said this is early preliminary data, but they are really noticing that in a couple months of data that the patients that were discharged by a virtual nurse were less likely to have a readmission within 30 days. And so that really has a financial and quality impact for the hospital. And then some outcomes on the expert oversight side. So we talked to UC Health, and they have triggers, and then they also kind of shadow with the rapid response nurse across 11 hospitals. So if there's a rapid response call, they bring in a mobile device with the rapid response nurse, and the rapid response nurse has to go and see another patient. They stay for 20 to 45 minutes, but the virtual nurse stays for 6 hours and monitors that patient. Did they do the follow-up vital signs after the rapid response call, pre and post rapid response? Are they, and that patient's so vulnerable there, at that point, they're either going to go one direction or another. So their outcomes, they saw an increase in early detection as evidenced by increased rapid response calls on those 11 hospitals. And across, they saw a 25 to 70% reduction in code blues. And we know that there's only a 26% survival of a hospital CPR. And of that 26% that survive, just minimal really get back to their pre-hospital, or pre-arrest level of functioning. And so that outcome is really priceless, I would say. And they also had some great impacts on their sepsis mortality as well. So, and there are a few good articles that have been published about virtual nursing that validate these types of outcomes, especially taking time off on the dismissal time. So those are some outcomes to share, and then your KPIs would probably be similar to those. And I think that was one of the questions. So I'm going to hand it off to Ashley to make sure that she has some time to share about how Equum Medical is really the people and process behind virtual care.
Thank you. So Equum Medical is striving to be the strategic health partner of choice. We have been in business for over a decade, providing that expert level of care in tele-ICUs and specialty cares from rural hospitals to tertiary centers from New York to California and Texas to Canada. Next slide, please. So we do that through a wide range of services. We provide physicians, specialists, nurses, sitters, virtual telemetry techs, and all of those people, we do that through a provider pod. And so what a provider pod is to us is we hire based on the 3 A's. That's they're amiable, they're able, and they're available. So we want to make sure that we have the right person to provide the right care at the right time. And they're assigned to facilities. So it's not just a phone call and you get some random person on the phone. You get a provider, nurse, or physician who is credentialed in your facility, who can chart in your electronic medical record, and who is licensed in your state. So where the provider is sitting is not matter, it's where the patient is sitting. So we want to make sure that we hire staff to those patients. Next slide, please. So this is a video, just a little snippet of what we do here at our virtual care center.
There is nothing more important in healthcare today than our workforce. Over the past 2 years, hospital systems have struggled to maintain experienced, talented, and qualified nurses in their units, leaving burnout and staffing shortages at an all-time high. What is the solution? The natural evolution of healthcare is to integrate technology and telehealth. Virtual nursing has become that solution. At Equum Medical, we recognize that we can't keep doing things the way we've always done, and that we want our healthcare experiences to have the same convenience and quality we expect in our daily lives. To combat our nation's clinical workforce crisis, Equum Medical has launched a virtual nursing program that serves as an extension of care to the bedside. With the power of the EMR, data analytics, and two-way audio-video, the virtual nurse is not limited to being a unit-level resource, but instead a valuable asset for patient flow across the enterprise. Learn how, through the power of telehealth, Equum can deliver nursing and specialist services to unburden your bedside care teams, increase clinical capacity, and help return clinical joy to those that we need most. Meet Equum Medical and meet the next generation of the digitally enabled clinical workforce.
Thank you for that. That's just a little snippet of what we do and how we take care of patients. Next slide, please. Okay. So the real question is, how do we redesign care? When I started nursing over 20 years ago, we had a team-based model, and we went away from that. We went to primary care, and from that, we know we don't have enough people, and so we've had to augment that design And we started with virtual sitters, and that was very effective in having additional bodies at the bedside to help provide that care. And now we're branching out into virtual nursing and using that same audio video technology to connect expert level nurses to support your staff at the bedside. Next slide, please. So what is virtual nursing? We use audio video equipment at your facility. So what you have, what Elizabeth presented, there's options. We can use them all. And we document in your electronic medical record. The difference is we have an environment here that is quiet and uninterrupted. So your staff and patients have the nurse's undivided attention. We collaborate with your care team model and your physicians, nurses, and ancillary staff to fill out that true team model instead of just a nurse and a tech. And we have the time to mentor new staff. This one is very important. We're non-judgmental. We aren't in it for the politics. We want to grow the next generation of nurses and support them in their critical thinking skills. It takes years to master that skill. And so having that support available to them 24/7 is essential. We all know night shifts on med-surg are your least experienced staff. And so being at the virtual care center, we have enabled nurses to come back to nursing who have 20+ years of experience who just can't walk that 20 miles a day or wrestle with the 250-pound patient or the 400-pound patient. They are here to transfer that knowledge to your staff, which has been remarkable. We have a lot of success with that. Next slide, please. So what do we do? As Elizabeth said, we do all the things. Clinical resource is our #1 service that we provide. That's that one-on-one episodic care. Can be one-on-one with the nurse or one-on-one with the patient. We have expert oversight all the time, which is nice. You know who works in your pod, you know what staff you're going to be working with every day. And then we can also provide specialty services, wound care nurses. We've had a request for pediatrics. So those are things that we look at depending on the need of your program and what you're trying to solve for. On the next slide. This is really what our day-to-day looks like for our virtual resource nurse. From admission to discharge, they can do anything that a bedside nurse does that does not require touching a patient. So with the technology that you've seen today, we can read the medical record number on the armband. We can be that skin check, that second eyes for the skin check. Of course, we can do all the documentation, the screenings, meds to beds, getting their medication reconciliation correct. We have the time to call those pharmacies that you don't. We also have the availability to call and schedule appointments, whether it's in-house for radiology or PT, OT, we can make that happen. And of course, mentoring. And then education is something that we start on admission and we do through the entire patient stay and ready for discharge. So on that day of discharge, it is not like, oh, let's push them out the door. They've had their education from their admitting diagnosis. We can teach them, we can video conference in their family, a translator. We can make sure that they actually understand their diagnosis, their treatment, and their discharge plan. So that's been very successful. Inpatient outcomes and staff experience as well, because they're not rushing to get the next one. The other thing that has been part of our resource program is the RN to RN handoff. So when they're admitted into the ER and everyone is busy, we know the bedside nurse has those other 5-6 patients. They can call our resource nurse, give that report. Your transport can move them to their room, and then we can give that bedside nurse report, and their admission stuff and paperwork, the administrative piece is done for them. Next slide, please. So we build every program with the quadruple aim. That's improved patient outcomes, improved patient experience, lower cost. We all know with the current margins and the staffing crisis, we can't afford to keep doing things the way that we've been doing them. And then provider experience. We help with the burnout for physicians, nurses, and other staff, having those resources available, if it's nights and weekends, if it's 24/7, we can do that. And I won't read the slide to you, but these are some of the results that we have identified with our past implementations and some of the lessons that we've learned in doing it. Next slide, please. So here at our virtual care center, we obviously have the resource nurse. That's the bulk of what we do. We have virtual safety sitters. So using the technology in your facility, we can reduce your one-to-one sitters. Virtual telemetry techs, this was a request for us during COVID. They just didn't have enough staff to watch the monitors, have the nurses take care of the patients, and manage all the care. So we do that as well. And then, of course, surveillance nursing. Next slide, please. So the benefits of partnering with someone like Equum is, as Elizabeth mentioned, we're the people and process. We don't do technology, we use what you have. So we have expert staff available to you. We have additional resources, and we can manage people on our side. I will tell you, you can set it up, but you're going to cannibalize your own precious resource. I've worked with several hospitals who have implemented one of these programs and they were already short-staffed and all their nurses wanted to go and do this. So how do you attract more staff to support your current process? And on processes, we can improve your flow. It's a minimal capital outlay for us. Obviously, we don't do tech. So, and then improved outcomes. We know what works. We know what does not work. We have done it for over a decade and have lessons learned. We also come in as a partner to your current process and staff. So it's not somebody telling you how to do it. It's how can we do it together. We are big users of Cotter's change management and implementation. So we work with your facility to identify the goal of the program and have a guiding coalition. I'll tell you, our most successful customers, we have a 90-minute webinar or on-site with their bedside nurses and leadership and talk through their process current, what they want it to look like. And if there were 10 things that we could eliminate for them, what could we do and help them? Those are the programs that are successful. Your bedside staff know what works and what doesn't. They know what's taking time away from the actual care that's prohibiting them from working to the top of their license. So that's where we have the expert services to come in and identify the process that would work best for you. And then on the technology side, we don't want to duplicate tech. We don't want to bring in additional monitor. We want one source that works throughout your facility, whether it's unit level, enterprise, or across your system. And AvaSure has that, which is fantastic. We can do sitters or nurses from your one tech that you already have. And then that improved integration. Those that have done some amazing things with Epic that will cross over and document real time in your medical record is essential. I think that is the future of nursing, and really that's why we're all here, is to talk about how we can do it differently. Next slide, please. Oh, that's it for me.
Thank you so much, Ashley. And we did, I think, have a lot of questions. So I'll open it up for, I think, Katie or Holly, we're going to read some of those for us.
Hi there. Yeah, this is Holly. A lot of questions coming in, so we'll try to get to all of them. Elizabeth, since you have probably experience in a lot of the pilots you've been working with, can you talk about the biggest challenges to implementing a virtual care program at new sites and possibly some solutions, some lessons learned?
Yeah, great, thank you. And I forgot to mention that I'm also on a task force with the Association of Medical Surgical Nurses. So they are writing a certification for a med-surg virtual nurse. I'm really excited about that. And so I got the chance to spend time with 7 leaders from 7 health systems in San Antonio for a couple days working on scoping the job of the virtual nurse and the knowledge and skills they would need. And so that was a great opportunity. So that, along with the pilots that are underway here at AvaSure and the conversations we've had and 1,000 customers, I think it's starting to really understand some of the challenges. And so I think one is the engagement of bedside staff is understanding this as a gift. And so to make sure that they are involved, one organization that we're working with, we were engaged with the unit-based council. So we went on site and did an presentation with the whole leadership team. And they asked us, can you come back? And it was a trip for us, but we made another trip back. And it was one of those cities that is too close to fly and too far to drive. So it was like a drive, but we really wanted to do that. And so we got to meet with the unit-based councils. And the nurses there said, this is what we need, not that.
Yes.
Yeah, so this is what would help us, and let's not like focus on that as much. And so I think really making sure, because one of the main points is to retain the nurses and support them at the bedside, and so involve them in the decision making. And I know that another organization had learned this lesson, and it seemed to make sense to them that it should be admission that the virtual nurse focuses on. And once they got started, they started helping out on discharges, and they completely morphed over to mostly focusing on discharges rather than admission. So I think that's one way to look at it. And the other is, as you're mapping out, do an impact effort map. Here's the problem, here are the different types of solutions, where are we today, and have a journey. Yeah, we would like to get to the point where we have a device in every room and virtual nurse is part of the care team and maybe overseeing LPNs and stuff, but where can we start today? And really test it as you're moving, progressing that way. And then the last thing I would say, and then I'll let Ashley weigh in as well, is to make sure that who is hired as a virtual nurse has a level of expertise, including providing a space of psychological safety when they're interacting with nurses and patients, obviously. But an example of that is I was talking to a leader who during COVID had virtual nursing program, and they were helping us more the expert oversight. And there was a newer nurse who was juggling a really intense assignment for the day. And the virtual nurse was helping her prioritize, doing this, we got to respond to this lab, this is happening on the other patients. And then she just stopped and said, am I doing a good job? And I just, that kind of broke my heart, because there are many nurses, people I talk to, but even monitoring staff who are in nursing school, and I say, yes, be a nurse, it's a great profession. And the idea that because of the pressures, the nurse was questioning herself. And to have an expert and a mentor who can say, yes, you are doing a good job, we're glad you're here, your patients are lucky to have you here, is so important. So Ashley, how would you answer that question?
Absolutely agree. I read an article last week, and it was talking about disruptive innovation. So while virtual nursing is amazing, you can't just add it on to what you're already doing. You really need that guiding coalition of what is your goal and what can we reduce off those bedside nurses to give them that time back. So absolutely, I think it is a collaboration between the virtual nurse, the key stakeholders, and the outcome, because you can't just throw something at it and hope it's going to change the process.
Mm-hmm.
Great, thank you for that answer. There's a good question. I think, Ashley, this might be something that you could speak to. There's a question about across state licensing. How is that addressed?
So fortunate. During COVID, we were granted access to the compact licensure for nursing. However, some hospitals, facilities, and states do not participate, and we know that that could end. But all of our nurses are licensed in the state where the care is being provided. So while we sit here in Nashville, Tennessee, if we are taking care of a facility in California, they're licensed in California.
Great, okay. There's a lot of chatter on the questions about ratios. So Elizabeth, maybe I'll tee this up to you. Let's talk about the different care models and which ratio, how, you know, the nurse to patient ratios you're seeing, and if virtual nursing actually affects overall nursing ratios.
I think that's a little bit of a chicken or an egg question. So I think that the ratios are being stretched because of all the reasons that we mentioned earlier. And this is a way to help alleviate some of that burden. So already, probably across the board, nurses are taking care of a few more patients or a little bit higher acuity patients than they were pre-pandemic. And then the expert nurse or the virtual nurse can help unburden that, rather than saying, let's add a virtual nurse so we can even stretch the ratios higher. So I think that's more of the perspective that we're seeing. I don't know, Ashley, if you're.
Agree. It does not eliminate that hands-on bedside nurse. You still have to have one of those to do those things that require touch and one-to-one care. But I definitely think it makes the current ratios extremely doable. So we're not overstretching those nurses, burning them out, and asking them to do things that, while they could do, they could be using their time and energy elsewhere. So.
Yeah, and I think NSI National has published a really good data around this, and I see it cited and recited, and they just came out in October again, and once I'm done talking, I'll try to type it in the chat so people know what I'm talking about. They said that the cost of one turnover of a nurse is about $46,000, and I think that they surveyed 260 hospitals. So it seems like a pretty valid survey to me. And then the turnover jumped from 18% in 2020 to 27% in 2021. So I think there is a very easy to measure ROI that is not about stretching the nurse to patient ratios further with virtual nursing at this point. I think we're moving into different types of teams and collaborative care models than from, when I got out of nursing school, it was, the primary nurse, Marie Manthe primary nurse model, where I was taking out the garbage, ICU nurse, yeah.
That's
doing
right.
every single thing myself.
Great, thank you. There's a few, this is another theme, is talk about the best approach to designing workflows for the virtual nurse.
So as I mentioned, Cotter, it is about the stakeholders getting together, that guiding coalition. Define your goal, what's the aim of the project, and then find those short, quick wins that you can go, hey, we did that, gave you this back, and then everybody buys in so you can tackle those more difficult tasks and challenges through the process work redesign. But that is key. Unit level nurses, their nurse council, if they're magnet or in that process, they have the answers. They just don't have the bodies. So if you listen to them, you automatically win. We've seen turnover actually decrease from this and staff satisfaction increase. One of the hospitals that I did this in, nurse satisfaction went up 18% after implementing a virtual nurse. Nothing else changed, like the leadership didn't change, the patient population didn't change. And they eliminated 100% of the travelers, which we all know how costly travelers are. So if you can do that on a system-wide level, think of the cost reduction on turnover and travelers alone, as well as keeping your staff at your bedside. I think that's really important.
Great, thank you. There's a question about if either of you have seen success with staff morale or retention with virtual nursing.
Yeah, so like I just mentioned, that was 2 med-surg units. They're the highest. We all know no one goes to med-surg to stay forever. And to see an 18% improvement in staff satisfaction through their nurse satisfaction survey and the decrease in turnover, that's what we're aiming for. That is the goal of virtual nursing. And they had 0 harm in CAUTI and CLABSI in over 380 days. That's significant given how during the pandemic, it's the first time ever that those numbers have gone up, and they had 0, not 1, 0.
Yeah, and one CLABSI, CDC says one CLABSI costs $50,000. Yeah. And I think the trend is not down. The trend is, I know we worked to incrementally decrease that year over year, and then it just bounced up so discouragingly high during COVID. So those are tremendous results. And I think there was another question written in by someone who registered, and it says, you know, do you have KPIs you recommend targeting? So I would recommend doing a nurse survey pre and post implementation. So you're not relying only on the nurse satisfaction surveys, which you might not be taking frequently enough to really target in on the impact of nurses. So I know one organization did that, and they really narrowed in on how comfortable are you on a remote nurse doing your admission. You know, how comfortable are you with them doing your discharge documentation? And once they implemented it, the nurses were like moderately comfortable with that ahead of time. But sometimes, you know, we want to own that. You know, I want to ask the questions myself, so I know it. But once they had done that, they were much more comfortable with it after they had experienced it. So, and then that point of the admission assessment, thinking, you know, I wanted to ask the questions myself, there is always a shift change anyway. So that information does need to be documented in the source of truth in the electronic health record, and it does get handed off from shift to shift. So, so that's just those are some of the issues to work through with the bedside staff.
Great. I know we're kind of inching towards the end of our time. Elizabeth and Ashley, do you have any other questions that you wanted to address or pose to the audience? Kind of our last final call here.
Yeah, I think I forgot to mention something, and that when I was talking about the technologies that we do integrate with the electronic health record. So I think I had said that is for virtual nursing, really the source of truth is the electronic health record. So I wanted to make sure that everyone was aware that the video can go right in. So the virtual nurse can just click onto the patient and then pull up the camera right from the electronic health record. So the view there. Just because Ashley, you triggered me because you said that's so important to have those workflows seamless and integrated. So that was a key thing. So thank you for opportunity, Holly, for catching up with something I forgot. Anything you'd like to add, Ashley?
I would just say, make sure you're hiring the right person.
Yes.
Being a nurse is hard, and you want somebody who can love and nurture your patient and your staff and improve your outcomes, because we all do it because it's an art and a science. But hire the right person. It's not just a warm body, and it's not just somebody checking off a box. So you want to make sure that that person is very engaging and understands the goal of the program.
Well said. Thank you, Ashley. I always enjoy speaking with you.
Yes, thank you for having me.
All right, and with that, thank you both. Thank you everybody for joining. And this will be recorded and sent out and available on our new YouTube channel. Thanks again and have a great day.
Thanks, Holly.
Thank you.